Good afternoon, everyone. Welcome and thank you for joining us today for the Integrated Planning webinar. My name is Inez Tamajong, and I'm the Program Associate at UCHAPS. Before we get started, I just want to make sure that everyone is working. Can you just, everyone confirm that they can hear me? If so, please type yes into the chat box. Okay, good. With us today are 5 members representing 4 different UCHAPS jurisdictions who will be sharing their experiences with integrated planning for HIV prevention and care in large urban areas. As many of you with us today already know, taking an integrated approach to prevention and care allows health departments and communities to focus and streamline their efforts and allows for the creation of a more coordinated and effective response to the HIV epidemic. Today's speakers will share some of the work they've done with integrated planning and the lessons they've learned in going through this process. We're going to hold all questions until the presentations are over. However, if you have any questions during the webinar, please feel free to raise your hand or type your question into the chat box and we'll put them in the queue to be answered during the Q&A session. After each speaker has given their presentation, the floor will be open for any questions for participants. So today we're going to begin our discussion with Jeffrey Campbell. Jeffrey Campbell is a native of Texas and is a graduate of Texas State University. Jeffrey has spent the last 16 years working in the field of HIV prevention while also being heavily involved in LGBTQ advocacy in Houston and around the country. Currently, Jeffrey works as the HIV program manager at the Houston Health Department. In this role, Jeffrey provides administrative leadership to the health department's HIV testing programs, PrEP project, and Data to Care project. In addition to this, Jeffrey gives leadership to the HIV program's Hearts Project, which has a staff of gay men of color who work as public health educators and provide services in the city's STI clinics and within communities of gay and bisexual men of color. Jeffrey also serves as the government co-chair of the Houston Community Planning Group and is the government co-chair of the steering committee of UCHAPS. Jeffrey, please go ahead.
Hello, everyone. Good afternoon, good morning to those of you who still may be in the morning hours. Funny thing happened on the way to the webinar. We had some technical difficulties. Interesting thing is that Inez and Ivory are here at the Houston Health Department with me, and some things in my office still went awry. So very happy to have the opportunity to talk to you today about the integrated plan that exists between Houston, the Houston Health Department and our Harris County counterparts and cohorts around HIV prevention and primary care or for medical care for those individuals living with HIV. Here we go. So what I think is very important to talk about when it comes to Houston Harris County and the work that we're doing is the way that money comes into Houston Harris County, and then how these services are provided and under the multiple umbrellas where they exist. So you can see this slide here. It's not a slide I'm going to spend a lot of time on. I just want to give you an idea of, for the lack of a better word, the craziness of how money comes into Houston and how we spend it to provide services. So starting at the far left, we have our HRSA funds and the HIV/AIDS Bureau, our HAB, and that funding comes to us through Ryan White Part A, Part B, and then on the Division of Community-Based Programs, Ron White Part C and D. Then we have the funding that we get from the Centers for Disease Control, or CDC, and that comes into our Houston Health Department. And then thirdly, on the far right side of the screen is our Office of Community, well, the U.S. Department of Housing and Urban Development. That money comes in through Office of Community Planning and Development, the Division of Special Needs, HIV/AIDS Housing, and then finally our HOPWA programs and Houston Department of Housing and Community Development. And some of that money then lands within our health department for CDBG programs. So when you look at this, you've got 4 different streams of money. You've got the county receiving funds, or the Harris County Public Health and Environmental Services, and then Ryan White. Then you have the health department, and you have our resource group as well. So the money here in Houston is spread across many different recipients. And I think the biggest point I want to make here when we're talking about the integrated plan is that the 3 major components are, it's Ryan White Planning Council, Houston Health Department, and finally the resource group. And it is all of those organizations or those I would say government, their government at each of our levels, all of those managing organizations and the community bodies that partner with us. So the Ryan White Planning Council and the CPG, the Community Planning Group that we have here in Houston on the prevention side. So it's key to understand that our big difference from some of our sibling cities around the nation is that our money is not sitting in one place or under one umbrella. It's split across several umbrellas. So when we move on to HIV planning in Houston, our joint planning began in 2011 with the first plan released in 2012. First plan released in 2012, and then of course the second joint plan was released in 2017. When we talk about putting it together, how it happened, our community planning group, or CPG, plans together with our Ryan White Planning Council, and in this process, because this is a very stringent process. There's a lot of work. There's a lot of people hours that goes into it. So I know CPG suspends several regularly scheduled committees to facilitate full participation. Both CPG and Ryan White are suspending those regularly scheduled committees to facilitate full participation. And then finally, our administration, our administrative agencies and staff planning process who contribute to the writing are our Ryan White Planning Council Office of Support. I think someone is on the call today from the Office of Support, which is under the umbrella of the Harris County Public Health offices, our Houston Health Department, and our Houston Regional HIV/AIDS Resource Group, Inc., or we love to call it the Resource Group. So those are the 3 managing organizations. They're also the 3 organizations that participate in the writing of our integrated plan here in Houston, Harris County. Our goals when in regards to the our integrated plan is, number 1, to increase community mobilization around HIV in the greater Houston area. I think that's plain and simple and put out right there for you. To prevent and reduce new HIV infections, ensure that all people living with or at risk for HIV have access to early and continuous HIV prevention and care services of utmost importance, and it stays on our radar here in Houston. Reduce the effect of co-occurring conditions that hinder HIV prevention behaviors and adherence to care. Reduce disparities in the Houston area HIV epidemic and address the needs of vulnerable populations. And then finally, increase community knowledge around HIV in the greater Houston area. So a lot of this language is still very friendly to the former President Obama's I just drew a blank. To our somebody help me. What is it? The President Obama, the Obama administration. Yeah, in-house, the National HIV/AIDS Strategies. I'm sorry. Please do not have me committed. Yeah, in-house, National HIV/AIDS Strategy. So much of this language is still very much akin to that particular strategy. So we still find it being very useful even at 2018 and moving into 2019 and 2020 for us. More goals: to reduce the number of new HIV infections diagnosed in the Houston area. And this gets to more specific numbers by at least 25% from 1,386 in 2014 to reduce them down to 1,004 by the time this particular plan comes to an end. We're talking about annual diagnoses. And then we're looking at number 2, maintain and, if possible, increase the percentage of individuals with a positive HIV test result identified through focused HIV testing who are informed of their positive HIV status, beginning at 93.8%, and that's our base level there was 2014. Increase the proportion of newly diagnosed individuals linked to clinical HIV care within 1 month of their HIV diagnosis to at least 85%, and that will be a jump up from 66%, which was the measurement in 2015. So we're talking about 21% from 2015 until the end of this particular plan. And then here we go with 4.1, decrease the percentage of new HIV diagnoses with an HIV stage 3 or AIDS diagnosis within 1 year by 25%, from 25.9% in 2014 to 19.4% by the end of the plan. 4.2, decrease the percentage of new HIV diagnoses with an HIV stage 3 diagnoses. Our next slide here, this is how we are structuring our plan, or the preparation for the plan, and these are the successes. What we decided and put into place early on in this process was that there would be 3 co-chairs. There would be a co-chair from Ryan White Part A, a co-chair from Ryan White Part B, and a co-chair from our community planning group. The next thing that led to a success for us is our leadership team included 19 self-disclosed persons living with HIV and AIDS, or persons living with HIV. It is critical that we have the voices of individuals who are either at high risk for or persons who are living with HIV as a part of these this leadership team that we developed for our integrated plan. There is a standing evaluation work group, and that work group, first of all, oversaw all evaluation related components of the planning process, and then it continues to conduct formal evaluations throughout the plan implementation. So there's initial work that group does in the developing of the plan, and then finally they continue to monitor and evaluate the plan in an ongoing pace. Then finally, we're talking about planning and successes on this particular side. There's an extensive financial and human services inventory of the Houston area. This was a very challenging undertaking here in Houston because of the geographical largesse of our area, as well as the number of agencies that are receiving funds that are related to this integrated plan. So there were in-depth interviews with 17 agencies, and of those 17 agencies, that made up about $55.7 million and employed about 486 FTEs. And then finally, an additional $1.8 million was captured in consultation with administrative agencies. So again, when we talk about Houston being 650 square miles, Harris County being 1,750 square miles, we're talking about a geographical mass. And then we're talking about a large number of agencies that are receiving prevention and care dollars one way or the other. That sums up to over $55 million and just under 500 FTEs. And that's my presentation. So I was quick and in a hurry, and I hope I've given you some information that's helpful, and we'll take questions later.
Okay, excellent. Thank you so much, Jeffrey. Okay, so Thomas, are you on the line?
I am.
Okay, great. So Thomas Noble is the testing program manager with the Community Health Equity and Promotion branch of the San Francisco Department of Public Health. He's a government co-chair for the newly merged HIV Community Planning Council, and he's been doing HIV STD testing work in San Francisco since 1991, with a focus on gay and bisexual men, transgender women, and with people who inject drugs. Thomas is a California HIV state certified trainer charged with training and certifying all new test counselors. In his work with the Department of Public Health, he is still an active HIV, HCV, and STI counselor with many of the sites funded by DPH. Thomas, whenever you're ready, we can get started with your presentation.
Great. So nice to, I want to say meet you all, but I guess I am not meeting you, but to present. So I am new to the government co-chair role here in San Francisco. Many of you knew Jose Luis. And so I'm stepping into his role within the council. So I think if anything, my perspective is more of like what happened after the merge and where we are now. So just that first slide, I think it's just kind of an interesting perspective. San Francisco is always a little bit off-kiltered. If you actually look at the picture and you straighten it out, it's this hill is so severe that it's just an optical illusion of what is actually happening there. So next slide. So I've just, yeah, there you go. So some tools. So basically kind of an overview or preparation. Talk about what we did to prepare, acknowledge how we acknowledge differences and similarities, acknowledging fears and hopes and opportunities with regards to the merging process. So next slide. So somebody said this already, but basically start early, and you will not be able to start early enough. There's so much communication and so much time and so many conversations that actually need to happen around this process. The sooner you have an idea of what you need to do or that you're going to go in this direction, just start engaging folks right away. Next slide. So part of what we did to prepare is meeting internally, which I think was actually some of the harder conversations, and they still remain to be some of the harder conversations with regards to prevention work and care work. The worlds are just so significantly different, and the cultures just so different that meeting internally and trying to get as much on the same page as possible was definitely key. Attending each other's meetings and starting to watch and see how things were different and what the similarities were and was important, but just making a list of what you actually saw was different, I think was really helpful. And I think at least for us here, culturally kind of pointing out differences is not something that we generally lean into or a skill set that people have. I think we're kind of raised to look for similarities and how we are the same, and in that process, you actually don't really acknowledge the diversity of the groups or the way they view things and things along those lines. So I just kind of want to call that out to make sure that people are there. Part of the other process was the fact that what was happening, we realized was kind of a misstep, was we were coming together, care and prevention, and then when we would go back to our bodies, we would report out, but we would report out from the lens that we had, and both groups were actually getting inconsistent messages. It was just subtle things, but those subtle things kind of added up and became more magnified when we went down the road. So what I would really recommend is the people who are coming to the groups is be the same body of people going to both groups, so both groups are actually hearing the same message from the same folks. It takes a time commitment, and somebody definitely has to be that kind of the holder of knowledge. Ideally, it would be a couple people, but the more consistency, the better. Next slide. So obviously, just as this kind of a logistics piece, but having a joint committee meeting that started to look at the nitty-gritty, the bylaws, the membership rules, all of those things, the logistics of what needed to go on, because I think the larger council is more around relationships and more the psychological processes. But then if you could have another body of people who are actually looking at kind of the lawyer end of things, that is really helpful. And then those people kind of communicating that back to the larger group for individuals who don't really get into the nitty gritty or understand the bylaws of either body they're actually sitting on currently and don't really value that piece of it. But somebody who can actually translate back what that will actually mean to them. So next slide. Somebody mentioned this as well, just an understanding of terms. These are all terms that I actually could say to somebody from a different world and they would actually have a different perspective. Even the word care, I could tell when people were using it, their definition of that word was very different than my definition of the word. And it was just the subtlety and the way that it was in the context of whatever the sentence or the phrase was. I was like, oh, they're actually saying this, but it's not what I think. I think hashtag is probably the best example that I can think that currently it's either a hashtag or a pound, depending on your lens, and often that's generational, to tell you the truth. So people are actually saying the same thing, but giving it different names. Next slide. So this is kind of more that psychological component. I think if people always, the expression of like we're building the plane as we were flying it is often how we were feeling during the process. So trying to communicate to people around where we were going was challenging, just because we weren't quite clear where we were going all of the time. And so within that ambiguity, people's anxiety actually rises, and it actually causes people fill in the gaps with misinformation or mistrust. So over communicating, I think, is what I would do. And then also just kind of labeling to folks. It's like, you know what, we're not sure where this will end up or what this will actually look like or what the meaning of this. And once we do understand and have more information, we will let you know. But I think just letting people know that you don't know is actually a really helpful way of actually addressing the uncertainty. Next slide. One of the biggest uncertainties that we actually didn't really understand until we got a little bit further in was just the fact that people thought this would be a grab for their pot of money. So somehow somebody from the other group would reach over and take their money, or somehow they would be assumed or something along those lines. And it's interesting, depending on who you were speaking to, everybody actually had the same fear. And nobody was actually thinking, oh, this is a great opportunity to actually reach across the table and get somebody else's resources. So once we started to figure out that that was happening and really saying, you know what, integration does not mean that we will be, having these funding shifts in a significant way. And so once we actually said that, labeled it and put it out there, you could actually see the anxiety kind of float out of the room in the processes, and people were less tense about holding on to whatever piece of the path they had. So next slide. This was kind of that acknowledging the differences and the subtleties that kind of came through. So cycles of funding are actually different. Roles are different. One group basically kind of values a provider's perspective. Another group kind of values traditionally a consumer's perspective, and those are different worlds. The prevention folks kind of addressed their audience, or who they're trying to reach is anybody at risk, which can be a pretty broad category. That's basically anybody who's sexually active or injecting any kind of substances versus somebody who's actually HIV positive and using services. So those lenses are very, very different, and you would approach something very differently. So I've noticed even one of the last bullet there, and what I mean by influencing, in the prevention world, we kind of would bring providers together and we'd have them present to the body about what they were doing, their best practice, what they were seeing in the field, and what they thought needed to happen. And in the care world, there's a culture of basically not, it's not ethical to actually influence another care member. So to actually get them to vote your way or to pitch for your community or the body was actually seen as a way that was unethical and not really welcomed. And so that energy still kind of exists. I'll sit around our body, our current new council, and I'm thinking we have such a valued expertise here in the room, yet people are not really given the mic to stand up and say what their life experience is and how it actually adds to the process. And if folks don't know the Dr. Seuss Starbelly Sneetches story, it basically kind of is the concept that people are different, and to acknowledge that. So, next slide. This was the other thing that I actually really kind of found helpful, was basically to get people to stop using the words care and prevention. So, and instead actually say specifically what they were talking about. So, whatever the service was, is it navigation? Is it adherence? Is it testing? Is it, what do you actually mean when you're actually trying to formulate that sentence or what you're trying to articulate? So I think these examples kind of speak to that. And I would really, even now, I still kind of will say in meetings, you know, if folks can actually, if somebody uses the word care or prevention, I'm going to say, what service are you actually speaking to, or what you are trying to articulate to the group? And to tell you the truth, for the most part, most people have stopped using these particular words unless they're actually referencing some kind of historical moment. So next slide. So these were a couple of quotes that I got from folks when I asked them about preparing for this. So this is basically, I hear those fears. This process is about unifying strengths and skills so we can have a better impact on what we're trying to do. So basically kind of acknowledging fears were happening and then refocusing the fears with regards to the larger goal was always kind of a critical process. And then the bottom one was basically the concept that people were really on their best behavior, and that actually kind of worked a little bit against us because they weren't really acknowledging when they were frustrated or that something was different from their perspective. It was like two people who were extremely polite, never quite getting past that space of like, you know, you've got some food on your face, or what you just said, I'm really curious about that because it doesn't make sense to me. It was more like, oh, that was great, and appreciative, and it just kind of kept us on the surface level of interaction for quite a long time. So the advice is almost like, don't be on your best behavior. Next slide. So somebody mentioned earlier as well, which I thought was good, having third-party individuals come in and help with conversations that are kind of hard or difficult, call out differences, acknowledge that change is hard on everybody, but we all react to it very differently. So whatever your perspective on change is definitely not the same perspective on somebody who's sitting next to you. So lean into the fears. So if people do have concerns or questions, or they think that somehow people living with HIV won't be represented, or prevention will be engulfed, or something along those lines. Actually, I mean, I would almost chart those out as you go along in each meeting. It's like, what are our fears moving forward, and how can we address them? Because in reality, most of the fears actually did not come to pass. And then you always want to kind of finish those conversations with talking about what are the opportunities of us working together. Next slide. I think this is actually just a concept of pulling folks together, and a unifying voice can be really helpful, and leadership needs to kind of demonstrate that, and making sure that the voices of people living with HIV or the people at risk for HIV are not diminished. So kind of refocusing energy often with regards to the bigger picture was really helpful at multiple times during our merge process. Next slide. Partnership with DPH. This is just good community planning as a whole, but making sure that DPH roles. The DPH for the prevention folks the role in prevention was different than it was for care. And so making sure that the DPH still acts as a partner and not necessarily a dictator or a leader was something that we continually kind of had to make sure that we put through to the planning process. Unfortunately, our merge was more of a top-down perspective, and so that kind of worked against us during the whole process, just because it did feel as if the DPH was kind of mandating this process, and I guess in some ways that we were. So that caused us to actually have to enter into even more of the conversations with more humility and more patience with people's concerns. The next slide. This was just Monday night. So one of the tools, so our body ended up being 50 members. And so what we have figured out as one of the tools for working with such a large group is usually each meeting, full council meeting, we will break into smaller groups and actually specifically discuss topics. So that seems to be allowing a space for people to come together outside of, not necessarily in committee, but people can mix with people who are outside of their committees and actually do some work and create a sense of intimacy. So if you've ended up with a larger full council, then make sure that you introduce the concept of small groups as part of the culture within that, those structures. Next slide. And that is it. So yeah, so any, I guess, questions from here?
Okay, great. Thank you, Thomas. Next, we're going to hear from our two speakers from Broward County, which are Jersey Garcia and Janelle Taveras. Jersey Garcia began her work in HIV prevention, education, and planning in the early 1990s as a peer health educator at her high school in New York City. Ms. Garcia has served as an HIV treatment adherence specialist, grant manager for a SANSA-funded HIV, college-based / community partnership on HIV and substance misuse prevention, and as a health educator for the Amigas HIV prevention intervention for Hispanic women. She currently serves as the HIV prevention planner for the Florida Department of Health in Broward County, overseeing the integrated plan implementation process, and holds a master's degree in public health with a concentration on community health education from Hunter College. Her colleague today, Janelle Taveras, has a PhD and MPH in epidemiology from Florida International University, where her dissertation work focused on HIV risk behaviors, previous HIV testing, and positivity among Hispanic women tested for HIV in Florida. Mrs. Taveras has over 12 years of experience in the field of HIV and currently serves as the monitoring and evaluation consultant for the HIV program at the Florida Department of Health in Broward County, where she has been involved in both the local and state integrated planning processes since 2013. Unfortunately, Janelle cannot be with us today. However, we were able to coordinate earlier and record her part of her presentation to share with you all today during today's webinar.
Okay, so this is Janelle speaking, and I'm going to talk about the early efforts and the lessons learned since the inception of integrated efforts in Broward County. So integrated efforts began in 2012 for us in Broward County shortly after the implementation of PS 12-1201. And after the joint CDC and HRSA Dear Colleague letter in support of integration came out, we knew that further guidance had to be sought. So one of the major lessons learned was that we identified a methodology to help guide integration efforts. And this methodology is collective impact, which is defined as the commitment of a group of actors from different sectors to a common agenda for solving a complex problem. And HIV in Broward County is definitely a complex problem. The methodology outlines 5 conditions that need to be implemented for collective success to occur. And they are a common agenda, shared measurements, mutually reinforcing activities, continuous communication, and backbone organizations. So after the identification of a methodology by which we had guidance to continue with integrated planning, There were 5 lessons learned. The first notable lesson was that integration could not be prescriptive. What works for one jurisdiction may not work for another. For example, Broward knew that integrating prevention and care planning bodies into one would make integrated planning more complicated than efficient because the culture, structure, and objectives of each of the group was so different. Second was that cultivating relationships was necessary to gain momentum and steer the plan in the right direction. However, meaningful engagement requires a lot of time. But knowing this ahead of time, you can plan to have meetings that may take all day, frequent meetings, especially in the creation of the plan, and know that this may have to continue into the implementation of the plan. Also, having an outside facilitator assisted with the process by ensuring that we achieved our meeting goals. Third, we noted early in the discussion about integration that we may be using the same words such as community or consumer, but the meanings for each of us were different. And also there was a lot of alphabet soup being thrown around in conversations. So we needed to create a lexicon of agreed definitions so that we're speaking the same language. The next lesson learned was that appropriate and continuous communication with the community was essential. But there's a lot of things we didn't know, how much to communicate, when to communicate, and I think we're still learning that lesson. Sometimes also the manner in which we communicate is not how our community would like to receive the communication about the integrated plan. Lastly, using shared metrics, such as the continuum of care, helped align activities early on and identify indicators for the plan. However, we still had to make some predictions for the prioritization of activities, such as what activities will occur in year 1, year 2, etc., which possibly has an impact on the current implementation of the plan. And speaking more about the current implementation plan will be Jersey Garcia.
So thank you, everybody, and thank you also for your patience. Dr. Taveras, Janelle Taveras, in her recording, provided a summary of what happened in the planning process. Basically, she gave a summary around what was the process and the selection of the, basically of what was the process that we were gonna take to create the plan. I wanted to talk to you now about what has happened in implementing the plan, what processes, challenges, and also progress we've made so far. So just so you can know a little shot of the integrated plan, what we came up with after it took almost, I think, half a year process of meetings, of facilitation, and we created a plan that a prevention and care plan that entails 4 goals. The 4 goals are in line with our NHAS, with the National HIV/AIDS strategies, are the same 4 goals that are included in that. So we are aligned with our federal mandate and suggestions. We have 9 objectives, 30 strategies, and over 112 activities. 23 of those activities were directly derived from the community's input. We also have a list of 9 indicators. These are the 9 global indicators that will measure our impact by the end of implementation, and we expect that we will end implementation of this plan in 2021. So that's just a broad overview of what the plan looks like. Next slide. Thank you. For year 1, which is 2017, when we began implementation, we had to get together and think about how we were going to create a platform to be able to monitor the implementation of the plan. So what happened was that there was a development of 3 specific groups, let's say, to help us monitor and implement the program. The first group we call the Funders Collaborative, and in that Funders Collaborative, is made up of basically the individuals, the grantees that receive funding, Ryan White funding, and that is Part A, Part B, C, D, F. We have HAPWA representatives, we have HIV prevention or CDC grantee sitting at the table in the Funders Collaborative. And also we have Broward County Schools because they receive CDC funding as well for their work on HIV prevention in the Broward Public Schools. So that group mandate or task is to assign the responsibilities for the goals and objectives so we can know what we are monitoring and what we will be implementing. And also when the group meets, they will be addressing the challenges in implementation. This group is currently meeting kind of more in a quarterly basis right now, but that's the makeup of that group. We have a second group, which we call the Integrated Plan Goal Teams. And the goal teams, we have goal leaders for each of the goals and also objective champions. So the objective champions and the goal leaders are tasked with making sure that the activities that were selected for implementations are being moving forward, and also they are also tasked in collecting data that have to do with the implementation of those activities as well. And finally, we have the integrated work group. So the integrated work group, I know that I came after to this position as an HIV prevention planner at the health department after the plan was created. And what I hear was that before the plan was created, basically the motto was integration without integration. So what we did, instead of having an integrated body of an advisory and planning body, so we know that Part A, Part B, and also HIV prevention here at the health department have planning and advisory bodies. So instead of bringing them all together or integrating those three groups, we have created an integrated work group with representations of those three bodies. We have 4 reps for the SFAN, the South Florida AIDS Network, which represents Part B or advises Plan B, Ryan White Part B. We have representatives from the HIV Planning Council, which advises and plans for Ryan White Part A, and the Broward County HIV Prevention Planning Council that that advises HIV prevention here at the health department and the CDC funds. So that's the integrated work group, and their biggest task for that work group is to develop strategies on how to engage the community, of how to engage the Broward County community in general in the implementation of the plan. So those are the 3 groups that were basically created to help us move the plan forward. We also in year 1 sat together, and especially with the goal leaders and champions, in selecting what were the activities that we were going to start implementing for year 1. As you noticed in the past slide, we have 112 activities and more than 112 activities. We cannot start implementing them all at the same time. So we sat together and decided on which activities we're going to begin implementation for year 1. Then the last part that we did, the last activity that we did for year 1 last year, was collecting information on what was going on with the activities that we decided to implement. So collecting that information and putting it in some kind of report that we can all understand, and that is what we're calling the Turn the Curve report. So for each goal, we created a small report, a short report on basically the challenges and the progress that we made in year 1 on those activities that we selected. So that was for year 1 in 2017. Next slide. So year 2, we selected the activities for year 2 implementation early in the year with the goal leaders and the objective champions. We are working on refining the processes for collecting data and assessing progress, because it's a lot of information and not everybody has access to the information. There could be activities that are going on in small community-based organizations or volunteer organizations that we don't know that are going on. So how do we know how to collect information? And what exact information is meaningful? What do we really need to collect? We are still trying to refine that process. and working on that this year. We are also working on engaging the community at large as new partners to implement the plan. We want to be able to bring, because right now we have a lot of health department and all the Ryan Y parts and HAPWA and the schools as part of this plan, but we're trying to see if we can engage other partners. Right now we have been able to engage partners like Walgreens to come to the table, and Equality Florida, which is another advocacy organization. So we're trying to see how we can bring other non-traditional providers and also community members to the table in monitoring and implementing this plan. We are also working on reviewing and determining some activities that we might not be able to accomplish that they were really great on when we came up with the idea or the activity, but now that we look at it and we're looking at funding, or we're looking at if it's really feasible, realizing that some things might have to be taken off from the activities and just realize that they're unattainable. And finally, we're working on seeing how can we communicate the plan, the progress we've made already with implementing the plan in a way that people can relate to it, that it's meaningful, and that they feel that it's important to them. Because we don't want to present the information in a way that it's just a whole bunch of numbers or how many activities been done, but why should people care? Why should people care about this integrated plan for Broward County? Next slide. So our challenges are, the first challenge is reporting to the CDC. Right now, we do not have any clear understanding of what we need to be reporting to the CDC. We have not received any guidance yet. The second challenge that we've been encountering is the interpretation of the plan. So each of the goal leaders and then objective champions are taking each of these goals, and sometimes some of the individuals that are trying to make sure that these activities are being followed through were not part of creating the plan. So they are sometimes interpreting it into how they feel that what this activity means. Sometimes they read an activity and they might interpret it a different way or a different way that the original creator of the plan might have interpreted. So that's been something that we have had challenges with in the interpretation of some of the activities, not all, but just a few of the activities that are included in the plan. The other challenge is meaningful engagement. As I mentioned previously, we have people that sometimes are invited to come to the meetings and talk, and share and see how they can support and be part of the process. But we have to create spaces where a lot of the individuals that we're engaging can feel like their input is meaningful, and that we don't lose them in the process. Because sometimes in this process, so much information, so much confusion sometimes, and as mentioned before in the previous presentation, fears too. So it's addressing all that at the same time and trying to find space for individuals to feel engaged in the process. Finally, consensus on the definition of success. I think we are kind of split in some of the members of the different groups of what is success. Is success reaching those indicators that we mentioned at the beginning of the presentation? Or is success that we are actually sitting on a table and talking and sharing? Is success is that we have representatives from 3 advisory and planning bodies that usually never work together or never sat in the same table? Will that be success? So it's really sitting together and agreeing, or at least getting to mediate some type of definition for what is success for us as we implement this plan. Next slide, please. And finally, progress. What progress have we made? We have had some program partnerships that I think are really great because of the integration of having this integrated plan. One of which is our test and treat program. And the test and treat program is rapid access to treatment and care And this is a partnership between the DOH, the health department, the local health department, and Ryan White Part A. So that, I believe that before we wouldn't do something like that, and especially prevention or the area of prevention, working with care so closely. The second progress that I believe we have made with implementing this plan is that we now have Ryan White, HOP1, and CDC grantees meeting and collaborating. Just yesterday, we had a meeting with the Funders Collaborative, and we were all sitting there and actually congratulating our partners from the Broward County Public Schools because they just received their funding for 5 more years, and also our partners from Ryan White Part F that received also their funding for another 5 years. Before, we wouldn't know who, if they received their funding or not, and we wouldn't know what resources are really out there or for our residents here in Broward County. The third progress I feel that we have made is having the HIV advisory and planning bodies engaged, at least sitting in the table and trying to figure out how we're gonna let the community, how we're gonna let our residents here in Broward County know about this integrated plan and what we're doing to turn the curve around our HIV epidemic. And finally, prevention efforts are part of the HIV care continuum. That, I think, has been, for me, seeing the process, our biggest accomplishment, because I noticed before I came that prevention used to work in silos. Care worked one side and prevention worked in another side, and they never really came together to collaborate, to talk about what they're doing. So this, I think, being able to have this integrated plan, working together on creating it, and also working together and implementing and monitoring that's been, I think, one of the most successful part is that now prevention is part of the continuum, of the HIV care continuum. And I think that that's it for now. I think that the last slide is just some information about Janelle and I. And I thank you again for hearing how we are monitoring and implementing our integrated prevention and care plan here in Broward County.
Okay, great. Thank you so much, Jersey. I want to remind all the attendees, if you have any questions, please put them in the chat box. We do have one question from Renee to all of the panelists. She wanted to know, how many years do your integration plans cover?
Hi, this is Jersey. Our plan is for 5 years, 2017 to 2021.
Hi, this is Jeffrey from Houston. Our plan is 5 years as well, 2017 to 2021.
And this is Thomas from San Francisco, and I'm going to say 5 years, just because it seems like the theme.
I think that's the common answer. I think that's the required timeline.
So are there questions?
It doesn't look like there are any questions at the moment. However, if
Can I ask a question?
Oh, sure.
The other panelists, how did this come about for you? Was it a dictate, or was it from the membership?
So this is Jeffrey from Houston. Our Houston folks, we started this before it became a dictate. That's why we've got now 2 under our belts. The first one we did was not a dictate, but the second one was. And I think Member Harbolt from our Ryan White administration office is also on this call. If she can, she may want to add some things to it, because she has really been a part of this process much longer than I have.
Okay, would anyone else like to answer Thomas's question?
This is Jersey from Broward County. I believe it wasn't a mandate, it was a recommendation. and once the recommendation was sent, then everything started moving.
Okay, great, thank you. Are there any last questions to all the attendees?
Hi, this is Amber Harbolt.
Hi, Amber. I just wanted you to chime in again because you've been a part of this process much longer than I have. Is there anything that you would like to add about our experience here in Houston with the integrated plan?
Oh gosh,
I know
it's a large part of what I do, so that's kind of a that's kind of drinking from the fire hose on that one. If there's a particular question, though, I'm happy to answer it.
Well, can you talk a little bit about how we got started here in Houston? Because we've got 2 under our belt, and what motivated us to start a little, maybe about 5 years sooner than everybody else.
Well, I mean, actually, you alluded to it that that we saw the value of it in the Houston area to have, we have these 2 great planning bodies doing complementary work, and each one submitting an integrated plan or a comprehensive plan at that point. And just really as a community seeing the need to not only be pulling in the same direction with both plans, but to be avoiding duplication of effort.
Good. Thanks.
So this is Thomas, and so it's interesting because we are now actually we're starting out in the process for our next funding cycle, looking at Hep C and STDs and kind of integrating those into the HIV work. So it's been just coming out of the integration of the care and the prevention world, and now trying to enter into integrating even further. It's actually working, and it's exciting to actually see folks, and even overdose prevention work is getting folded into it. So, and building on the expertise of all those planning bodies. So it's overwhelming, to tell you the truth, but at the same time, it just feels like the right thing to do for the community.
Hi, this is Jersey. I just wanted to mention, for us, is having those individuals being part of our Broward County HIV prevention planning. So any of the planning and advisory groups, those individuals are engaged through that process, and representatives of each of those 3 bodies are in our integrated work group. So what we're seeing is that we're hoping is that their voices, those representatives bring the voices of those individuals that they're working with in their individual groups, advisory and planning bodies, that they're bringing it into the work group space. And also the meetings are open to the participants.
I concur with Jersey. This is Jeffrey in Houston. We do a lot of ongoing work with both our CPG and our Ryan White Planning Council to ensure that we have representation from the communities and the audiences that are most impacted as a part of those particular bodies, and giving voice both on the prevention and care side. So we began with those people that are already a part of the work that we're doing, and utilize those people as needed to bring in similar voices from those communities that are most impacted, that might not always be around the table. And it was a lot of phone calls and a lot of emails and a lot of conversations and a lot of pleas and a lot of thank you, because it is a challenge to commit to a process that is this large and this detailed. So a lot of energy going into recruiting and then thanking folks for being a part of the process.
This is Amber. I'd like to add, you're absolutely right, Jeffrey, but I'd also like to add, We did not have any all-day meetings whatsoever. We kept our meetings to around 2 hours, and we had them at various times throughout the day and various days throughout the week, because we understand that people who are working, people who have maybe complex medical needs, and so they've got many doctor's appointments, people who rely on public transportation to get around, may not have all day to sit in a meeting the way that someone who gets paid to do this for a living may. So that's always been part of our you might call it a driving principle, is how can we make this accessible to the people who are going to be using it or who are going to benefit from it. And that was one of the ways, just in structuring frequent brief meetings as opposed to, you know, long, exhausting ones.
Yeah, I
And
think,
also,
go ahead.
I was going to say, and also for our leadership team, we had 3 co-chairs for that process, one from Ryan White Part A, one from a Ryan White Part A representative, a Ryan White Part B representative, and a representative from prevention. And so they brought all of their community members and staff. We made sure that each of our smaller work groups within that process had a person living with HIV and someone with maybe more institutional knowledge leading that process and bringing people in. So we really tried to make sure folks were engaged and felt heard every step of the process, and that they sort of bring other people in with them when they feel heard, when they feel like they have true stakeholder interactions with us.
Yeah, that sounds good. And it's so funny. I always think food is like magic. So I'm not sure what that does, but it definitely goes a long way to actually keeping people engaged at all levels, and making sure that the populations that are vulnerable and hungry basically can join us and get something out of it. And we've even had small stipends with regards to transportation and things along those lines. So just some simple logistics, having those in place was really helpful.
And we also have a pretty extensive process for making people aware of both the Planning Council and CPG. We spend 17 weeks giving a free training on how to engage in the HIV planning process. People from the community sit in on the CPG meeting, the prevention body, as well as a Ryan White Planning Council meeting, and we spend a lot of time and effort and money in cultivating stakeholders on the front end, so that when something like this comes up, we have many people who are not only willing to help and pleased to help, but who see the value in their help and who have a strong knowledge and skill foundation to be able to help. And again, that's on both sides for both prevention and care. So yeah.
All right, thank you. I want to thank all of our panelists again for joining us, as well as Amber. Thank you for jumping in and sharing your insights. We really appreciated that. Thank you all to all the attendees who stuck it out through our technical difficulties today. I apologize for that. Before we end today's webinar, if you could all please go to the SurveyMonkey link. I'm posting it in the chat box, and please fill out a post-webinar survey. That would be very helpful for us. And thank you all once again.
Thank you. Goodbye.
Bye.